who's contributing at the political level, who are contributing not only at the international level, but they're playing pivotal role to their alma maters and starting all these programs. I have no hesitation in saying that these three people not only contributed, in the university, but they are the pioneer to start the first family physician certificate course. They help us in designing the curriculum as well as monetary supports in the form of millions of rupees to start this certificate course which just finished a couple of months before. I will take another 3 or 4 minutes because, sir, our university is a naive university. We are just 2.5 years old. I'm not sure what the pediatrics are to this age. So I will show you few slides how we are evolved in last 2 years. Can I have my first slide, please? Next. Next. Doctors, they are trained to hold the management of the epidemic also. Then we have the health research course, and again we have again became the torchbearer to have the first collaboration of foundation year program with the Royal College of Emergency Medicine. This also show the trust and educational institution on this newly built university. Then, sir, the research. I will not go into the detail, but this is our research vision, and this is our generic model of 8-step and faculty, as well as the visitor research programs. This is, sir, but again, I'm thankful to the Chairman Higher Education Commission, who believe in quality, who believe in system, and from last 2 years we were struggling, and this time I heard this lab, which is the first by the Higher Education Commission now. Then, sir, community. This is the vision of the worthy minister. I first time heard him, couldn't get the chance to have the detailed discussion, that he is the mastermind behind the university health coverage program. And the university health coverage program, first I learned, as a physician from him, that it needs a quality care, easy accessibility, and affordability. And I'm thinking that the last component is already there in the form of health Sahulat card, and so many people are benefiting. Sir, no program can be all over the world successful, it is unless collaborated with the university. Otherwise, it will remain as the administrative program like all other program, like Birinzi sport program or other program, unless they are universities are the integral part of that. Me and you can go, but when it's the part of the university, then these programs are have academic links, academic audit, and they are going to survive. This will be my submission that if you have to a wide range program, this must be linked with the university, and the universities are responsible for the patient care as well as the community health care. Then, sir, last but not least, we have a primary health care system. We have the secondary care like district headquarter and Tahsil headquarter hospitals, and then the tertiary care hospital. And unfortunately, this all is mixed up. The people who to be at the community hospital, they are in the tertiary care hospitals, which is wastage of the time as well as not improving the patient care and research. So, sir, our university is linked with the patient care with a new program and new agenda, which is putting the patient first. Ultimately, every education and training at student level, postgraduate level, and faculty level, and research must lead to a applied program for the community health and administration. So this is will be looked after by the university. We have done a 6-month trial on that. Lastly, we have expanded our 9 programs, rather 12 programs on the patient health care, like nephrology, pulmonology, oncology, gastroenterology, and last 2 months in the Rawalpindi medical hospitals, because I'm the chief executive of those hospitals also. And these 12 new departments will be run by the university. Next. So this is, sir, we see 3.1 million patients here. You can well imagine what sort of healthcare we are providing. Next. Sir, this is the new idea for the government. I gave it to the previous government also. They were working on this. Sir, the solution of tertiary care is the big city hospital, which is called the Rawalpindi Medical City, which is comprised of 51 institutions. Now, the healthcare not like with this, that the one person has a angioplasty, develop the upper GI bleed, and then rush to the Holy Family, and then need a radio intervention and rush to the Islamabad. So we have a concept of medical city where all the disciplines are available under one roof, even sport medicine, even transplant medicine. So there is a newer concept. I'm sure this will be, inshallah, perceived by the Higher Education Commission and the government. Next. Last but not least, the Rawalpindi Medical University alumni. I again salute to Dr. Zahid Rafiq, Dr. Shahid, Dr. Rao Babar, and Dr. Nadeem, and I can't see Dr. Sakab here, who stand behind the university. This is the university which is asked by the alumni, not by the government, and they're still standing behind all the good happening like Family Medicine Conference today. Next. Lastly, sir, what is the role of Rawalpindi Medical University in family medicine? So, sir, we are the proactive sort of program which will be giving to the present, inshallah, council after this session. And this is all we have done. What we need is next. This is the courses run by the Family Medicine Department. Next. What we need, sir, is inshallah, the noding of Higher Education Commission, and we can start the residency program in family medicine very much this year. I, sir, thank you for your kind attention.
Since I'm a co-organizer of this conference, I have the enviable task of thanking a number of people who made it happen. I want to do it now. First of all, before I do that, I want to express a special thanks to Dr. Zafar Mirza, the Special Assistant to the Prime Minister, for joining us at this occasion and giving us the support of the government. Thank you very much, sir. I also want to express a special thank to Dr. Nahid Usmani, the President of APNA, for her strong interest and strong commitment to this program. The people who worked on this, Shahid Saib from the APNA side and Dr. Zainul Abidin and Fazal Abbas Mekan from HEC, thank you very much for organizing a very, very good conference. Our media team and other participants also contributed quite significantly. And finally, Dr. Omar, the Vice Chancellor of RMU, was always not only available but very actively engaged in the planning of this conference. So thank you, Dr. Saab, to you as well. Ladies and gentlemen, when I was the age of one of the students here, I remember seeing a picture. There was something called the Barricades of Spring, a student uprising in France. And one of the things they had done was the students had taken over one of the halls of government, and they had put a banner on it or a poster or something. My French is not that good, but it said L'imagination prend le pouvoir, which means imagination takes over. Imagination has come into power. The reason I thought of it is that I remember the time that Zafar and I and Nahid, when we used to be thinking about, oh, shouldn't this be done and shouldn't this be done? We were kind of rebels trying to bring about a change, etc., etc. Trying to say, if only people had some intelligence, they would do things right. Well, now I look at us. Zafar is sitting as the Minister for Health. Nahid is sitting as the President of APNA, and I myself am the Chair of HEC. If we don't do it now, shame on us. It really is something that we had fought for all of our lives. And we need to make this happen. Now, what is that we need to make it happen? One of the things that we were always concerned about. And in Pakistan, it has a long history, which I will mention in a minute. But I think to put it simply and, shall we say, in somewhat political terms, the very simple idea is putting people first. Putting people first. And as I mentioned to you, this idea has a longer history. I think Mr. Bhutto, in his term as the Prime Minister in the 1970s, actually gave voice to this idea in a very significant way. And he said, well, the purpose of the government is to put people first. You know, the power should go to the people. And he focused on a lot of things. One of the things that he focused on, which I now has kind of come full circle, is that the healthcare system has to reach the people. So for the first time, those of you who have studied the history of this country, he set up the basic health units, he set up the regional health centers. This entire network was missing at that time. He was the one who thought, well, we have to make sure that things reach the people. Let us create access. Let us create access. And it was a fundamental change in thinking. I was a young officer in the Planning Commission at that time, and I remember thinking that it's such a unsettling idea. It's not the way things have been used. We didn't used to think about health systems in terms of actually going out and reaching people. The health system was, oh, well, have medical schools and have some big hospitals and those kind of things. But this idea that it's people who are first was not really very significant. I was thinking also of the work that Zafar did in his days when he and I were battling on the streets. As very soon after he graduated from college, he set up something called the Network for the Rational Use of Medicine. And the Hello? Ji. In the 1990s, Dr. Zafar Mirza had set up the Network for the Rational Use of Medicine. The purpose was, of course, that we have to think about the person. We have to think about the user of the medicine. We have to think about their health, not about, just pushing medicines, but about the entire health system. I've also collaborated with Dr. Nahid Usmani, who is one of the brightest minds coming out of the APNA framework, the APNA community. And that's a very high threshold because some of our best people are part of APNA. APNA, of course, has had a long history of working in Pakistan, and of course, I'm sure Dr. Usmani is going to mention some of them. My own personal involvement has been in 2 or 3 things which I should mention. There was a time when Dr. Naseem Ashraf and Khalid Riaz had set up something called Apna Sehat, a program of promoting health systems in rural areas in Pakistan. And of course, Naseem Ashraf is from Peshawar, so he said, I'm allowed to say Apna Sehat because we Pathans, we mix the genders a little bit. So he put Apna Sehat, and that was a very successful program. And then at a second stage, they set up something called the Human Development Foundation. And when it was launched at an Apna meeting in New York, I believe it was 1997 or maybe 1998, 97, I think. Dr. Mahbub ul Haq, the late Mahbub ul Haq, was a keynote speaker. I was also one of the speakers at that meeting, and it was a tremendous rush of energy of looking at all of these people who were so committed to human development in Pakistan. People were pulling out their checkbooks and contributing. They signed up, became foundational members. And of course, Dr. Usmani was a founding member of APNA at that time. She was also instrumental in the Association of Pakistani Physicians in New England, very appropriately called APNI. And not only as part of APNI, she was instrumental in bringing into place this merit program, which of course we'll hear about, in which the educational contribution to the Pakistan health education system was organized together with APNA. So I think a lot of these things have come together. Putting people first, which is also the top agenda of this government. Of course, Zafar is going to talk about it in more detail. The idea of building the education system, making sure that we have the appropriate skills and the appropriate expertise, building up quality, all of these things are now coming together in one place. One last thing that I should mention is that my own work, particularly in the 1990s when I set up the Sustainable Development Policy Institute, was looking at environmental issues, and our view was that the biggest challenge to health in Pakistan was not on the curative side, it was on the environmental side, on the preventive side. In fact, there's a wonderful study by Carter Brandon of the World Bank. When the first burden of disease study came out, I believe 1994, in which he looked at the burden of disease in Pakistan and found that when you convert it not only in terms of mortality but also disability adjusted life years, that roughly 80% of it was because of environmental factors, poor quality water, poor quality air. And so, we need to think about health in a more integrated manner. And I don't think there's any better person than Dr. Zafar Mirza to think about it this way. So, ladies and gentlemen, I think that the whole circle is coming to a close. And this, to my mind, this conference is one of the ways of expressing some of those ideas that have come together. We do have our internal processes, focusing on people, putting people first. There are things like the Sehat card, and there are other like SAS program, etc., etc. But this part of building up family medicine is going to be a very central component of this. It is also coming together that we have had a long-standing relationship with APNA. It is the gold standard for the engagement of expatriates in the affairs of a country. It's really the gold standard, not only for Pakistan, but anywhere in the world. APNA really has been very, very actively engaged in the work in Pakistan. My hat's off to them, and thanks to them for the work that they have done. That support is there. From HEC, we are very, very committed to the issue of quality, and I think if we bring all of these things together, we can make tremendous progress. I should mention that when we first focused on access, inclusivity, we did not pay enough attention to maintaining quality. So the result was that, a lot of times what happened is that the expansion of access took place at the expense of quality. It need not happen. Our commitment to you is that we will continue to expand access, but we will also focus equally on quality. This example, the expansion of access and quality, we know in the education sector, we've increased the number of seats, we've increased the number of universities, but quality has not kept up. We are now trying to reverse that process. But it has taken place in other areas as well. When again in the 1970s, when Mr. Bhutto tried to expand, said rural electrification, everybody should get electricity. And yes, of course, that was a very important initiative to take, but then we got load shedding because there wasn't enough electricity to go around. So, putting access and quality together is of fundamental importance. And I think now we have come to the point where we can put access and quality together. And our commitment to you is that that is exactly what we should do. Now, this conference is picking up one very important component of the agenda of putting people first, and that is family medicine. And by family medicine, I don't mean only the general practitioner who's sitting there, but the entire complex of how do you empower people to take charge of their own health. And that does mean creating family medicine as a desirable category, as something in which you can be successful not only monetarily but also professionally. It does mean that. But it also means investing in environmental health. It also means investing in nursing. It also means investing in a proper system from primary, secondary, and tertiary, that all the system will need to come up. And finally, it also means disseminating health knowledge across the community health as we call it. So all of these things are part of this component. We are very happy that these elements are part of the conference. We hope that you will come up with very good recommendations, which I'm sure that the government would be very happy to hear. Environmental health, community health, health systems, nursing. Nursing, I have to tell you a personal story. When I was doing my PhD at Harvard University, as all PhD students are supposed to teach, and one of the very bright women who was taking my course, she was a freshman or a sophomore, you know, and they would come to you for consulting about various things. And one of the times I asked her, I said, what do you want to do after you graduate? And she said, I want to become a nurse. Now, I had grown up in Pakistan, in which there is a caste system. So there is an upper caste Brahmins who are the doctors, and then there's the Shudras who are the nurses and the orderlies and so forth. I was shocked to discover there's no caste system. They are different professions, with different skills, and they are equal. And this was a kind of a mind-altering experience for me. I was really amazed to hear this. And then you realize that, you know, it is people who follow their passion who produce great success in life. And our task is to remove these artificial blinders that we have put in front of people. Our task is to create the basis for excellence. And that is what we at HEC are committed to do. So ladies and gentlemen, I wish you great success.
And Omar, invited chairs, speakers, panelists, respected international and national guests, RMU faculty, and dear students, Assalamu alaikum. It's a special honor for me being here as Ravelian from 5th batch to come back after all these years, after 40 years. I remember when this Latif Auditorium was built and the first program held here, I was here. So it's most honor for me to come back in this position in my alma mater. The introduction of APNA and its chairman and its committee merit will be the part of Dr. Nahid Usmani's address. I'm here primarily to acknowledge and thank all the individuals and institutions which help us bring about this conference, which is going to start today. It starts, the merit actually started 13 years ago as a committee of APNA, and it's indeed the highest point in APNA merit 13-year history that today we have the first international merit conference here in RMU. This conference is an important milestone.
Assalamu alaikum, everyone. So just by the fact that I'm a pediatric oncologist tells you that I like challenges, that things that are easy to do, I really believe are not worth doing. So when I took over the helm of APNA, which is the Association of Physicians of Pakistani Descent of North America, I wanted to do something meaningful for Pakistan. The opportunity for starting or to start addressing the problem of primary care in Pakistan seems to be the crux of how we can improve health statistics in Pakistan. So could you advance the slide, please? So here are some statistics of Pakistan. The population is about 2007 million. The median life expectancy for men is 66 years and for women 68 years. When you compare it to another South Asian country who also comes in the lower income countries, we are lagging behind. Sri Lanka, men live at least 7 years longer and women about 12 years longer. The mortality under 5 is 69 in Pakistan, whereas in Sri Lanka it's only 5 or 7. Currently in Pakistan, 54% of children are immunized compared to 99% of children in Sri Lanka. The maternal mortality is extremely high, one of the highest in South Asia and in the developing countries. Okay. All right. So about 40% of people above the age of 11 smoke. How is that for a statistic? 40% of Pakistani people smoke in this country. There's contraception prevalence is only 26%. There is only a third of the women get the appropriate antenatal care. Next slide, please. And then when you look at communicable diseases and non-communicable diseases, we have a very high load of communicable diseases that we should be able to prevent. And our non-communicable disease incidence is growing. 50% of the national burden of disease is related to hepatitis, tuberculosis, other communicable diseases, maternal child health, undernutrition, and the, thank you. And for non-communicable diseases, ischemic heart disease is now responsible for 8.4% of the deaths. Respiratory infection for another 8%, strokes about 6%, and again, blood sugar is prevalent in about, oh, I can't see the slide, about 12%, high blood pressure in a quarter of a population. We have endemic tuberculosis, malaria. We have 9% of our population has hepatitis B or C, which is extremely high, the highest in the world, and HIV is rising. So those are our statistics. How can we improve it? When we look at Pakistani health spending, it's uneven, and our focus is very different. So 2.7% of GDP is spent on health, but 70% is allocated to tertiary care. Less than 30% is focused on preventative measures, and less than 0.1% is on maternal child health. And if you look at where Pakistanis are getting their health, most of them are getting health from private hospitals and clinics. About 20%, less than 20% go to teaching hospitals and governmental hospitals, and the rural healthcare units and the basic healthcare units, which should be the primary healthcare first stop, is less than 1%. So clearly the focus of our healthcare is not aligned with delivering uniform healthcare to all the people of Pakistan. I just want you to review Sri Lanka's data with, I've given you the numbers for Pakistan. Family planning, they have 68%, their population is served compared to 36% of Pakistan. Antenatal care, we have 36%, they have 99%. Immunization is 99%. The tobacco non-use is 85%. These are the numbers that we want to look at. When you look at the expenditures, yes, they do spend a little bit more than what Pakistan spends, but they are not spending at the same level as developed countries like Britain and United States of America. So can we change? What can we do to have similar outcomes as Sri Lanka, which is a South Asian country and is considered to be a low-income country. So there are certain imperatives we have to focus on, and that has to be primary care and prevention. We have to reverse the budgetary constraint and start spending money on primary care rather than tertiary care. It does not matter that every institute have a bone marrow transplant unit, but it does matter that every institute has a family medicine department. We need to develop effective maternal child health so that our maternal mortality rate, our infant mortality rate, our neonatal mortality rates decrease. Right now, we are as high as Afghanistan and Nepal, so we need to decrease those numbers. We need to increase our immunization rates, and that can only happen if we go towards a school-based immunization schedule, and perhaps screening for malnutrition, undernutrition, all those things our children deserve. We need to have a public education. Right now, I was very pleased to see that there is a lot on coronavirus that we are hearing on public TV, media, newspaper. We need to have public education on communicable diseases, on safe disposal of syringes and needles, on nutrition, on smoking cessation, and we need to get our media, television, social media, everybody on board so the message goes through. There's education of the general public. We need to reduce the wastage of specialist and tertiary care resources that basically take care of the routine illness, because in Pakistan, if you have a headache, you go to a neurosurgeon. If you have a sore throat, you go to an ENT surgeon. You don't go to primary care. And that is a huge problem because ENT surgeon and a neurosurgeon has his own job to do and not to deal with all the headaches. Similarly, where Pakistani high blood pressure, hypertension, heart disease may be very peculiar to our own, pharmacogenomics, for our own culture, for our own ethnicities, and we need to develop indigenous guidelines of how we should treat these diseases and how we should prevent these diseases. And if we don't have strong family medicine and primary care, we won't be able to develop these. So we need more trained primary care in doctors, in nurses, in midwives. We need advanced practice nurses. We need 4-year trained midwives who can appropriately do antenatal care and postnatal care and have safe deliveries. We need to develop family medicine residency, both MCPS and FCPS, in all teaching institutions. Rather than have 10 different diplomas from 10 different universities, we need to have single exam, single qualification, so that if somebody has family medicine, whether they are from Khyber, whether they are from Jinnah Sindh, whether they are from Multan, everybody knows that they have passed a single exam, which is standard. We need to develop screening programs. Those are things that are basic medical care in the United States, and that's what we need to do over here, because every person deserves that training and access. So what is general practice? General practice versus primary care. Primary care is to the individual and family members, from youngest to the oldest. It emphasizes both health promotion and disease prevention. And the primary care for the doctor coordinates the specialist care. The patient doesn't go directly to the specialist. It's the primary care who directs that. So there has been an effort in Pakistan to develop family medicine and primary care. PMDC came up in 2014, a directive to develop family medicine programs in all medical schools. Similarly, CPSP started the MCPS and the FCPS many years ago, but the number of those slots and those trainees and staff has not increased. because the career path is not that clear for academic family medicine people. So let me tell you about APNA. Oh, this slide is to the side. But APNA constitute Pakistani physicians in North America. The first generations were the ones who went to medical school in Pakistan, but now we have a rising second generation Pakistani Americans who are going to medical school there. For most of us, about 43% of the 18,000 Pakistani physicians in US are in primary care. They chose primary care as their primary specialty. APNA started in 1977. It is the largest non-profit ethnic medical association in USA. There are over 50 component societies, chapters in every state, and of course we have alumni institutions for all the medical schools in Pakistan. And you find APNA physicians in all kinds of work environment, in academia, in primary care, in rural, in urban, you name it, we are doing it. We have in biotech, Pakistani physicians. So we represent a very broad group of individuals. Our mission and goals are to foster scientific development and education, and we want to develop liaison with other medical organizations. One of our main missions is to orient newly arrived Pakistani physicians and help them in their adjustment to their new country. We have always been involved in medical education and healthcare in Pakistan. As Dr. Banoori mentioned earlier, that we were involved in, we started Apna Sehat, then we started Human Development Foundation. Both of them are running as independent NGOs. We do a lot of advocacy and policy engagement with the legislative bodies in USA. And we have been involved in philanthropy and a lot of educational projects over the years. And these are some of the projects that we have done. I will not go into detail, but they encompass a wide range of activities that we have done. So why is APNA interested in developing primary care, and how can we help? So when we started talking about family medicine in Pakistan, we had a lot of APNA physicians in family medicine who came together, and we formed a subcommittee of family medicine. We also reached out to Association of Pakistani Physicians of UK, and they have a big group of primary care physicians as well. We were also invited by Dr. Zafar Mirza last year for the overseas Pakistani collaboration, healthcare diaspora, basically, how we can come together, and Dr. Zafar Mirza will be addressing that. So we felt that as APNA, we can offer with faculty development, with local institution, and we can help them start training and guidance to establish family medicine programs. We can help the primary care physicians with continuing professional educational credits and education so that we can update everybody based on American standards, what the best evidence-based care is. We can develop research collaborations with the institutions here to develop guidelines. We can help engage with other stakeholders to develop the family medicine across. So as APNA physicians, we can visit on short duration, visits to interact with the institution and be formal trainers and examiners. We can develop resources and toolkits for starting family medicine programs, which may include curriculum, online module, recorded lectures, question banks, and assignments and workshops. These can be offered online or in person, and many of the places like Professor Umar mentioned, they have the family medicine department. We can help augment it further. We can have an online platform via the Apna Merit, and we can have a cohort of master trainers who can come in and increase the trainers in Pakistan, the educational faculty, to lead the family medicine program in this country. So I will stop there. I think Apna, APPS UK, and other expat organization are keen to.
Some ideas and reforms that sometimes may not be very palatable. That slur is also thrown back at me. कि ये तो अमेरिका से हैं, although in 3 decades of professional career I've been there only 6 years. But I'm fantastically happy to be amongst friends and colleagues. Of course, Dr. Nahid Usmani, who I had the pleasure and privilege of working with at Shaukat Khanum when she was setting up, and we were part of the original initial team of SKMT. And of course, with other friends and colleagues up in the stage here, and many faces that I see down here. What I'm going to do is try to walk you through some of the ideas, and these are ideas and intentions, but nevertheless, these are being put in place, and I hope that they will get put in place to benefit really the person who's suffering at the end of the day, and that is the Pakistani citizen. You heard Dr. Nahid Usmani talk about the really horrible statistics as far as healthcare that we as Pakistanis are suffering through. So something needs to be done. Now, our vision and aims, I think, are collective. It's not the Prime Minister's task force that thinks this way. I think all of us think this way. All of us do wish that we actually have quality healthcare, whatever that is. And it's defined a million different ways, but we do want it, and we want curative, and very importantly, as you heard, preventive or primary care integrated into this whole paradigm. And what we really want is for this to be governed locally. You will keep hearing this word. You might get sick of hearing it by the time I finish, but I'd like to stress this, which is governed locally. We also want flexible and capable governance that allocates resource according to, again, local need. Again, responsive to local desires. And of course, something that's accountable, and again, accountable in a very local context and to benchmarks and dashboards. Not accountable to people making surprise visits to bathrooms, but rather, that's important too, but rather to have systems that across the board will measure progress and performance across time. And I have to tell you that as far as the structure, the khadokhal, the broad layout of the primary care structure in this country is concerned, it was laid out decades ago. But as Banori Saab said, it's one idea to say, well, we'll get electricity to everybody, but you can't have enough to supply everyone, so now you have a network of supply, but not enough supply. You had the same problem with this whole network of primary care that was set up in the 60s, 70s, and all with good desires and intentions. I tell you, I don't take away anything from previous governments and ideas and intentions and decision makers. I think everybody tried, but sometimes complex problems are a little bit hard to do. If you look at the network of this whole BHU, RHC, etc., every medical student knows this backwards and forwards and can draw this for you and can expound on how many BHUs are there connected to an RHC and how many thousand people it serves and so on and so forth. It is almost like out of SimCity. Has anybody played SimCity? Anybody know what that is? Yeah. So, you start making this idealized concept on a piece of paper and you say, well, this is how it's going to be. It was SimCity of healthcare. In fact, it all not only was it on paper, it actually got built. इसके संगो खिश्त भी हैं, उसके बारे में भी बात करते हैं. It actually is brick and mortar. But we've struggled for some decades in this country to actually
बिस्मिल्लाहिर्रहमानिर्रहीम. जनाब डॉक्टर तारिक बनौरी साहब, प्रोफेसर मोहम्मद उमर साहब, डॉक्टर नाहिद उस्मानी, डॉक्टर शाहिद रफ़ीक, and my friend Dr. फैसल. सबसे पहले तो मैं आपको मुबारकबाद पेश करना चाहता हूँ कि आपने इतने टॉपिकल सब्जेक्ट पे ये कॉन्फ्रेंस बुलाई. It's always a pleasure to come back to Rawalpindi Medical College as a former student who has graduated from this college, and it's always I look forward to come back. I would also like to appreciate very much the initiative which is taken jointly by Rawalpindi Medical University, Higher Education Commission and APNA. And especially APNA because our physicians and health professionals who are living abroad, they have a very special concern to see things improving in Pakistan, and especially in health sector. They see very well developed health systems, they are part of it, and there is a sense of responsibility in them that how we can also give back to Pakistan and see Pakistan health sector improving and reaching up to the standards that they themselves are part of that health system, which is very understandable. Health diaspora Pakistan से related जो rest of the world में है, it is round about 30,000 doctors alone, first generation doctors. इनकी बहुत बड़ी concentration यूनाइटेड स्टेट्स ऑफ अमेरिका में है, कनाडा में है और यूनाइटेड किंगडम में है. और हमारे यहाँ वक्तन फ़वक्तन बहुत सारी organizations of doctors living abroad, APNA being the largest one, and APPS, the counterpart of APNA in England, UK, they have been making very important efforts through different programs, projects, contributions, capacity building activities in Pakistan. And we as a government are trying to channelize better their possible contributions which they are already making and which can be made. तो हम एक प्रोग्राम पे काम कर रहे हैं जिसको हम कहते हैं पाकिस्तान हेल्थ डायस्पोरा इनिशिएटिव, यारान वतन के नाम से हम इस प्रोग्राम पे काम कर रहे हैं कि जिसमें वो लोग भी कि जो बाहर हैं पाकिस्तान में कंट्रीब्यूट करना चाहते हैं, नहीं कर पाते, उसकी बहुत सारी वजूहात हैं और उनके पास कोई प्लेटफॉर्म भी नहीं है. तो उसके लिए we are trying to establish this and we will be unfolding it in future. मैं थोड़ी सी बात करना चाहता हूँ आपसे जो डॉक्टर नाहिद उस्मानी ने अपनी प्रेजेंटेशन आपके सामने की और बहुत सारे पाकिस्तान के हेल्थ इंडिकेटर्स आपको प्रेजेंट किए. ये बड़ी ट्रेजिक सिचुएशन है इस वक्त पाकिस्तान में with reference to the health of the people of Pakistan. एक लंबी लिस्ट है जो मैं आपको गिनवा सकता हूं और आपको बहुत मगमूम कर सकता हूं. इट्स वेरी सैडनिंग. We are on top of the world in various negative indicators in health. Whether it is polio, whether it is EPI, whether it is hepatitis C, whether it is tuberculosis, whether it is maternal mortality rate, whether it is under 5 mortality, whether it is neonatal mortality, and the list goes on. So then the question is कि इस चैलेंज को, which is not less than a national security challenge. I have no other words to use for the accumulative effect that these challenges can have on any society, on any economy for that matter, on productivity of the people. 40% अगर आपके बच्चे स्टंटेड हैं तो व्हाट डज इट मीन कि आपके आने वाली जनरेशन का 40% are physically and mentally stunted. This alone, if you pick, is enough to understand the quantum of the tragedy that I'm talking about. और फिर हमारी जो पॉपुलेशन ग्रोथ है, अगर इसी रफ्तार पे हम रिप्रोड्यूस करते रहे तो अगले 30 साल में वी विल डबल द साइज दैट वी आर टुडे. All economic growth, all productivity, all development will be undermined and diffused by the sheer size of our population. 2.4 is our population growth rate, and 36.1 is our contraceptive prevalence rate. These are one of the lowest in Asia. So we can spend hours talking about the situation that we are supposed to address as all health professionals, policymakers, politicians, leaders. But then from where to start? And what is the VN? तो इस गवर्नमेंट की, प्राइम मिनिस्टर साहब की टास्क फोर्स जिसका अभी डॉक्टर फैसल जिसको बारे में बात कर रहे थे, मेरी अपनी एज ए हेल्थ मिनिस्टर VN तो बड़ी क्लियर है. इट्स 3 words: यूनिवर्सल हेल्थ कवरेज. But it is easy to say these 3 words than to implement these 3 words. But what is universal health coverage to begin with? It's 3 things. Every citizen according to their rights must have essential health services that they need, number 1. Those who cannot pay for those services, the government should take responsibility for paying on behalf of them. And the services, and that's the third dimension, and the services which are delivered are of quality so that they can have effect, desired effect. तो अगर ये VN है और ये इसकी 3 डायमेंशंस हैं तो हम इस सिलसिले में क्या कर रहे हैं? इस गवर्नमेंट का हेल्थ रिफॉर्म एजेंडा at policy level, at governance level, at health organization perspective, governance perspective, service delivery perspective, सारी health reforms are aimed at making it possible the VN of universal health coverage. I'll very quickly also tell you कि जो मैंने 3 डायमेंशंस की बात की है, इसको हम रियलाइज करने के लिए इन 3 डायमेंशंस में खास तौर पे क्या कर रहे हैं. If we say everybody has a right to health services that they need, so obviously everybody means without distinction, first of all, without any prejudice as their right. So uske liye, when resources are less, you have to prioritize. So you have to define what do you mean by essential health services. And to define essential health services, you have to develop a package of essential health services. And once you develop that prioritized package of essential health services, then you have to decide कि इसको किस लेवल पे डिलीवर करना है और किसने डिलीवर करना है. At what level of health care these services should be delivered and by whom. Health system research हमें ये बताती है अब, after having researched many health systems in the world, कि up to 70% or more, this is very important point that I'm going to make, up to 70% or more essential health services, especially in low and middle income countries, can be delivered at the primary health care level. 70%. तो अब आप वो स्टैटिस्टिक याद कीजिए जो अभी डॉक्टर नाहिद उस्मानी ने आपको प्रेजेंट किया कि हम खर्च कहाँ पे कर रहे हैं. अगर 70% services can be delivered at the primary healthcare level, so are we spending 70% of our budget on the primary healthcare? The answer is exact opposite. Actually, we are spending 70% on tertiary level hospitals. So obviously, you have to inverse this equation, but before that, you also have to define essential health services. और उसके लिए हम इस वक्त पाकिस्तान में we are almost towards the completion of this very important critical task that we have developed a national package of essential health services, which we are going to implement where we can implement ourselves at the federal level and share with our provincial governments so that they can also use it, modify it, implement it. Second जो बहुत important issue है वो ये है कि अगर आपकी poverty level से नीचे रहने वाली population पाकिस्तान में almost 50% है और आपकी health service delivery 70% के करीब private sector में है, तो how they are going to buy those services? तो उसके लिए vision और policy ये है कि those, as I said earlier, the second dimension of universal health care, those who cannot pay, government will pay on their behalf. कैसे? कैसे? हमने इस गवर्नमेंट ने जो सेहत इंसाफ कार्ड स्कीम शुरू की है उसका मकसद एग्जैक्टली ये है, to provide health insurance to those who cannot pay, and government pay the premium of poorest families on their behalf. So out of between 14 to 15 million poorest families in the country, currently as we speak, we have already provided this health insurance to 7.5 million families through Sehat Insaf card. और ये सारी इंश्योरेंस जो पे की जाती है फॉर हॉस्पिटल एडमिशंस आर इन प्राइवेट सेक्टर. तकरीबन 300 के करीब प्राइवेट सेक्टर हॉस्पिटल्स के ज़रिए ये हेल्थ इंश्योरेंस प्रोग्राम वर्क कर रहा है, स्प्रेड ऑल ओवर द कंट्री. और तीसरी जो डायमेंशन है क्वालिटी की, उसके ऊपर भी बहुत ज़्यादा काम करने की ज़रूरत है. हमारे ज़्यादा लोग हॉस्पिटल्स में एडमिट होकर इन्फेक्शंस लेकर आते हैं बजाय इसके कि वो ट्रीट हों वहाँ पे. अगर मैं सिर्फ एक स्टेटिस्टिक आपके साथ शेयर करूं So that will speak volumes about the health care that we are providing to the people of Pakistan. Pakistan is the country with highest per capita injections which are given every year to the people in Pakistan. 8 to 10 injections per capita. And if I add another dimension to it, you will jump out of your seats. 95% of these injections are not needed in the first place. They are unnecessary. So this speaks about the level and the volume and the state of the quality of healthcare in the country. By the way, ये injections कौन देता है? मैं और आप देते हैं ना, हम भी देते हैं. क्वैक्स की डेफिनेशन को भी चेंज करने की जरूरत है. There are qualified and unqualified quacks. Before you ask me to leave the stage, let me move on. अच्छा, अब बात यह है कि अगर हम ये कह रहे हैं कि 70% health care can be delivered at the primary health care level, so what is the state of our primary health care and who is providing this primary health care? आपको कुछ statistics डॉक्टर नाहिद उस्मानी ने बताए. Let's stick to this 30-70%. 30% of the healthcare delivery is taking place in the public sector facilities and 70% is taking place in private sector. Let's dig a little bit further into it. public sector में जो हमारे doctors बैठते हैं, हमारे basic health units, rural health centers, तहसील headquarters, district headquarters, hospitals के अंदर, और ख़ास तौर पे primary health care facility पे, यानी basic health unit और rural health centers, how we train them to become GPs or for that matter, family physicians? Do we? Actually, no. You pass out from a medical college, you do your house job, you apply to the government service, and one fine morning you receive a letter कि फलाने basic health unit में जाके आप उसका चार्ज संभाल लें. ऐसे ही होता है ना? तो वो उस दिन से ये सीखना शुरू करता है कि मैंने basic health unit को कैसे चलाना है, लोग किन प्रॉब्लम्स के साथ मेरे पास आते हैं, और मैंने इस हॉस्पिटल को, इस छोटी सी फैसिलिटी को मैनेज कैसे करना है, मेरा स्टाफ क्या है, मेरी मेडिसिन्स क्या हैं, बर्डन ऑफ डिजीज़ क्या है, चीफ कंप्लेंट्स क्या हैं, और मेरे स्टैंडर्ड ऑपरेटिंग प्रोसीजर्स क्या हैं, और स्टैंडर्ड ट्रीटमेंट गाइडलाइंस क्या हैं. ऑन द जॉब ट्रेनिंग शुरू होती है. वी आर नॉट मेकिंग एनी डेलिब्रेट एफर्ट इन इन्वेस्टिंग in our doctors who are manning our primary health care facilities in public sector. Let's talk about private sector. Who is providing primary health care in private sector? Primary health care actually is a dispersed phenomena in the private sector. लेकिन इसका bulk जो है, it is produced by GPs. कोई लाइन ड्रॉ करनी बड़ी मुश्किल है और ना हमारे पास इसके लिए कुछ रिलायबल स्टैटिस्टिक्स है. बट थ्रू आवर ऑब्जर्वेशन, थ्रू आवर एक्सपीरियंस वी कैन टेल कि बहुत बड़ा बल्क प्राइवेट हेल्थ केयर का इज प्रोवाइडेड बाय आवर जीपीस. लेकिन इसके साथ साथ सारे हमारे जो हर लेवल के प्राइवेट हेल्थ केयर फैसिलिटीज़ हैं, चाहे वो छोटे हॉस्पिटल्स हैं, चाहे वो बड़े हॉस्पिटल्स हैं, उनकी ओपीडीज़ में भी प्राइमरी हेल्थ केयर प्रोवाइड की जाती है. लेकिन लेट्स स्टिक टू द जीपीज़. Who is GP in Pakistan? The GP is also the same natural history of a doctor who we just placed in the BHU is the same doctor जिसके पास अगर कुछ resources हैं तो वो एक अपनी private clinic भी खोल लेता है और बाहर लिख लेता है डॉक्टर फ्लां फ्लां registered medical practitioner और वो GP बन जाता है और वो जिस दिन अपना क्लिनिक खोलता है तब वो फिर सीखना शुरू करता है वहां पे by trial and error, throw in the commercial side of it, तो commercial commerce drive करती है to large extent the quality of care that we provide and what patients can pay or cannot pay. जब हमने ये लाड़काना में जब ये हुआ HIV AIDS का एपिडेमिक तो उसको हमने जब देखा जरा क्लोज से तो one attributable factor which came out in big way was the reuse of disposable syringes. Well, who were using it? It was not just quacks, by the way. बहुत सारे GPs भी थे उस इलाके में और वो क्यों यूज करते थे ये? वो इसलिए यूज करते हैं कि अगर वो हर दफा एक नई डिस्पोजेबल सिरिंज खोल के टीका लगाएं तो उसकी कीमत वो पेशेंट पे नहीं कर सकता. लिहाजा अगर वो पेशेंट पे नहीं कर सकता तो बजाय इसके कि हर दफा वो नई सिरिंज खोलें वो उसी सिरिंज से दूसरे को भी टीका लगा देते हैं. इट इज सिंपल इकोनॉमिक्स. The question is, as a state, as a government, as health ministries, have we done anything to invest in these GPs who are providing bulk of primary health care in private sector? The answer is obvious, we haven't. तो इस कॉन्टेक्स्ट में ये बहुत ज़रूरी है कि हम बोथ पब्लिक एंड प्राइवेट सेक्टर में जो हमारे जीपीस हैं अनट्रेन्ड जीपीस आई वुड कॉल देम उनको अपग्रेड करें, उनको इंसेंटिवाइज करें, उनके अंदर इन्वेस्ट करें उनकी ट्रेनिंग में so that they can provide those essential health services in reliable and in quality manner. तो इस हवाले से ये जो आज की कॉन्फ्रेंस है बहुत इम्पॉर्टेंट है. मैं इस सिलसिले में थोड़ा सा आपको मज़ीद बताऊं कि मैं जब WHO में था तो हमने 22 कंट्रीज़ का एनालिसिस किया था ईस्टर्न मेडिटेरेनियन रीजन में कि what is the state of family medicine and family practice in these 22 countries, which is whole of Middle East, Pakistan, Iran, Afghanistan included, North Africa included. तो हमारे पास बड़े दिलचस्प स्टेटिस्टिक्स आए थे. अभी जो डॉक्टर फैसल सुल्तान बता रहे थे आपको नर्सिस के हवाले से, बायने ही यही सूरत हाल फैमिली फिजिशियंस के हवाले से. The line that we drew was कि we need at least 3 family physicians per 10,000 of the population. तो इस थ्रेशोल्ड पे विच इज ए मिनिमम थ्रेशोल्ड जब हमने स्टेट ऑफ अफेयर्स देखी तो उसमें सूरत हाल बहुत ही बुरी है. पाकिस्तान में चंद हजार फैमिली फिजिशियंस हैं प्रॉपर, चंद हजार, नॉट मोर देन 5,000 जिन्होंने प्रॉपर पोस्ट ग्रेजुएशन की हुई है फैमिली मेडिसिन के अंदर. और अगर हम इस रफ्तार से पाकिस्तान में 3 फैमिली फिजिशियंस पर 10,000 ऑफ पॉपुलेशन प्रोड्यूस करते रहे तो फॉर द टोटल पॉपुलेशन विच बाय द वे इज ग्रोइंग एट द रेट ऑफ 2.4, कब तक हम अपना desired objective achieve कर सकेंगे? It will take at least more than 100 years. But then the question is, okay, what do we do about it? Should we wait for 100 years or we accelerate this? तो उसके लिए we developed a short-term and long-term strategy. This is the crux of what I'm going to say today. And I think this is something which we all should ponder. हम तमाम लोगों को जो concerned हैं इसके बारे में और कुछ होता हुआ देखना चाहते हैं और उस सिलसिले में contribute करना चाहते हैं, अगर हम इस point के ऊपर converge करें तो we can actually make a difference. A short-term strategy and a long-term strategy. If you keep fantasizing कि पाकिस्तान में 3 family physicians properly with proper post graduation MCPS या FCPS या उनके equivalent degrees कर लें तो आपको 100 साल इंतजार करना पड़ेगा. लेकिन अगर हम इसके लिए कुछ innovative strategy अपनाएं तो ये बहुत short circuit भी किया जा सकता है, इसको बहुत ज़्यादा तेज़ भी किया जा सकता है, accelerate किया जा सकता है. कैसे? We think that we need to develop a very contextualized 1-year program for upgrading all existing GPs in public and private sector. And we should develop a system to incentivize GPs in both sectors to take up those courses. And we should celebrate them, we should recognize them, we should provide them incentives. If they are in public sector, they should have a career path associated with taking up that 1-year course. And if they are in the private sector, sorry, पहले मैंने public sector कह रहा था, if they are in the private sector, then we should also incentivize them by actually expanding our health insurance programs by taking them into the loop if they do this. That's the way to go about it. और इसमें ये मैं आपसे बिल्कुल थ्योरी नहीं आपको बता रहा, इसके ऊपर बहुत काम हो रहा है और बहुत जल्द हो सकता है. I know Dr. Muhammad Umar, Khyber Medical College, few universities in Lahore, Karachi, they have taken up this task. The only issue is that we need to bring some standardization, we need to bring some convergence, and we need to bring some consensus. That's the approach that we want to take at national level. We should have one course with one curriculum which should be credited, which should be recognized, and which those people who take up this should be incentivized to do this. मैं उम्मीद करता हूँ कि ये जो इनिशिएटिव आज यहाँ पे ये जो सब्जेक्ट है of family medicine and promoting absolutely the 4 bullet points that Dr. Naheed Usmani presented, जिसमें फैकल्टी की डेवलपमेंट भी है, जिसमें मेडिकल एजुकेशन की भी डेवलपमेंट है, जिसके अंदर पॉलिसी एंगेजमेंट की भी वो है और जिसमें रिसर्च भी है. ये अगर हम एजेंडा एट नेशनल लेवल अपना लें और कन्वर्ज कर लें उन तमाम पार्टीज़ को और उन तमाम स्टेक होल्डर्स को कि जो इस सिलसिले में डेवलपमेंट देखना चाहते हैं, तो गवर्नमेंट रोल ये है कि हम वो प्लेटफॉर्म प्रोवाइड करें कि जहाँ पे तमाम लोग आपस में बैठ के एक अप्रोच के ऊपर एग्री कर लें तो पाकिस्तान में बहुत बड़ी हेल्थ ट्रांसफॉर्मेशन आ सकती है. थैंक यू वेरी मच.
Thank you, Dr. Zafar. Ladies and gentlemen,